So that can be tenderness to palpation. So when you're assessing, them from the outer area, when you're palpating that joint, they can have some tenderness there. They can start wincing their eyes when you're feeling in that area. Those are kind of signs that they might be having that. There can be swelling of the joint area. You could see some facial asymmetry, right? Because oftentimes when there's inflammation, that can lead to swelling. And then another one you want to take note of is find out what their range of motion is. Is it very limited? Do they have pain on opening and closing? Things of that nature. So I know we mentioned this, but this is something I want to make sure I emphasize. That way, when you have patients that come in with problems like this, you kind of understand the baseline care and baseline management for these type of patients. And it's important to understand that you're not going to completely eradicate, the pain. That's anytime you're dealing with patients with TMJ, that's not your goal. Your goal is you want to improve their quality of life by alleviating the pain. So if you put the patient in the right mindset, you say, hey, we're gonna, see what we can do to kind of decrease the amount of pain you're having or alleviate that, versus if you tell the patient, yeah, we'll get rid of your pain, because that's not a practical result, right? So one of the important things is when you're sitting down with the patient and, figuring out what's going on, you're talking about your treatment. This goes with anything. You want to make sure you set the right expectations of that patient, so that way when you do deliver the treatment, they're kind of in the right mindset. So if I go to a patient and tell them, yeah, we'll completely get rid of your pain, this and that, and if they're having pain but it's not as bad as before, then you've kind of failed that patient, right? Because you told them something that you weren't able to do. So you have to understand with patients that have chronic TMJ disorders, the goal is to alleviate that pain. Okay. What are ways that we could do that? Like we talked about, I kind of mentioned it throughout this PowerPoint because it's very important that we emphasize these things. Soft diet, reducing function, see what kind of medications they may need, fabricating mouth therapy, just conservative kind of therapy that you want to do for that. Why? Because like we said, we'll alleviate the pain, decrease the dysfunction that the patients might have, and we kind of educate and counsel patients on what to expect and the expectations that they should have going into treatment. Yeah.
So are these inflammatory disorders not related to rheumatoid arthritis?
No, they are. So oftentimes, patients can have systemic issues that can lead to inflammatory disorders like that, whether it's rheumatoid, whether it's osteoarthritis, things like that nature. Soft diet is very important. I know it might seem really basic, but I wanted to have a specific slide on it because it's very important we tell patients about this. Oftentimes you'll just throw that in there after you do an extraction, tell them, oh yeah, soft diet. But it's important to emphasize that stuff because it really helps expedite the healing. It helps with their active range of motion, whether it's opening or closing. Why is that? Because you want to think about the joint and what you're doing to it. You don't want to put a bunch of forces on that joint. You kind of want to prevent overloading it. You want to decrease the activity of that musculature. So that's kind of something Julian mentioned with why we do Botox sometimes. If certain conservative therapies aren't working, then you can do Botox injections in that area. That helps decrease the muscle activity in that area. That's kind of the same thing with soft diet. It helps decrease that muscle activity there. And then it can range from a full liquid diet to hard chew foods, but you have to cut it into small pieces, stuff like that. Yeah. So let's talk about the pharmacotherapy in regards to TMJ. So we want to make sure that we understand, when you're prescribing a medication, it's not going to be the ultimate cure for that patient. It's just something that's kind of added with, the comprehensive care. We talked about lifestyle changes. So if they're biting their nails or constantly clenching or bruxism, things like that, you want to make sure you address that. Make sure you address their diet, and then on top of that, you can give a prescription for some certain medications that can help. But I don't want you guys to think of this as a single little cure for that patient. You want to prescribe them at regular intervals. For example, you can do 4 times daily for 2 weeks. Oftentimes, if I see a patient that has chronic, TMJ disorders, I'll prescribe medications for a month, and I'll have them follow up, see how they're doing, and then we can refill the prescription at the follow-up if needed, or tailor whatever scripts they might need, situations like that. So can anybody tell me the difference with NSAIDs and corticosteroids and like how they work? Because you guys have done extractions before, right? So when you guys do extractions, I know a lot of you guys, when I ask you what do you want to prescribe, a lot of you guys will tell me ibuprofen. So that's an NSAID. So how does that medication work?
Inhibits COX-1 and COX-2.
Yeah. Yeah, so it's important to know how that stuff works, right? You don't want to prescribe something to a patient and not understand, you know, the mechanics behind it. So let's say you have a patient that comes, why is that important? Let's say you have a patient that comes in with, they've had a colon resection or colon cancer or some sort of GI disorder. Why is that important when you're prescribing?
Bleeding? Someone with bleeding?
Huh?
Bleeding times?
So it has something to do with the COX-1 and COX-2, he says. So one of them is kind of gastroprotective. The other one, if you inhibit that, then, you know, it can lead to increased bleeding in that area. So that's something we'll talk about in this slide here. So this is a pretty important slide I want you guys to kind of understand here. So I want you guys to look at this area. Sometimes we have corticosteroids here, okay, and this arrow points to where it works. And sometimes we have NSAIDs, like what Faraj said, where it works. We said they can inhibit COX-1 and COX-2. So we have those two types. So corticosteroids will inhibit that phospholipase, and that's kind of, you know, what happens here when you inhibit that, you don't release these here. NSAIDs work in this area. So those are the two types of inflammatory medications that you'll often see with TMJ. There's a lot of cytokines, as you guys can see here on the slides, and that can help increase the inflammatory cascade. So when you're prescribing these medications, you inhibit release of those inflammatory cytokines. That leads to decreased sensations of pain. So that's kind of how it works here. So let's look a little more into NSAIDs. So if you look here, you can see you have your COX-1, your COX-2, and you have your traditional NSAIDs that can block COX-1 and COX-2. So look at this right here. We have gastric protection, right? So sometimes COX-1, it releases something called prostaglandin 1 right here. Okay? What that does, it leads to gastric protection. If you have a patient that comes in with a bunch of GI problems, then you don't want to inhibit this, right? You want to make sure that this is still active, right? Does that make sense? Mm-hmm. So that's why you have selective COX-2 inhibitors that you would prescribe in that area. Okay? So oftentimes it can non-steroidal anti-inflammatory, right? That's what an NSAID stands for. So it's anti-inflammatory. You're decreasing the inflammation, whether it's from these things here, myositis, capsulitis, synovitis, things of that nature. Side effects, like we said with the COX-1, COX-2, with COX-1 specifically, can include gastric irritation, allergies, liver dysfunction. Some common NSAIDs that you'll come across, like you guys all know, naproxen, ibuprofen, diclofenac. And because of fewer GI side effects and minimal effects on platelets, COX-2 inhibitors are becoming a lot more popular. Sometimes just the cost of those medications can kind of hinder a patient from going out and grabbing those versus, you know, your standard ibuprofen, things like that. Okay. And then if, you know, those aren't working, you also have, you know, opioid analgesics that you want to prescribe in conjunction with NSAIDs. So, you know, opioid analgesics are important because that decreases, you know, sensations of pain, but we also need to reduce that inflammatory aspect of the problem that's going on with TMJ. So that's why, you know, NSAIDs are kind of fundamental, and you can kind of support that by giving opioids as well. Because sometimes when you alternate between the two, it helps a little bit with the pain. But you want to make sure you're addressing kind of that underlying cause, which is the inflammation in that area. And that's why even after you do an extraction, oftentimes you prescribe an NSAID and you can give an opioid on top of that. But the NSAID is important to reduce that inflammation in that area. So we talked about corticosteroids, so I want you guys to understand kind of where they work in you know, this cascade here. So the corticosteroids kind of work up top here. They inhibit phospholipase, and that inhibits all of these things here. And these all can lead to cytokines and stuff like that. That can lead to increased pain. So if you're blocking this up top here, then you're blocking all of this. You have decreased sensation of pain. So it's just important to understand where they work. Right? Corticosteroids work up here, NSAIDs work right here. Often oftentimes, when you prescribe these, long-term it can lead to some complications like osteoporosis, diabetes, hypertension, you're decreasing an inflammatory response, right? So that's something you kind of want to be cognizant of. And then there are also muscle relaxants that you can give. I have a couple of them listed here: cyclobenzaprine, carbamol, things like that. They can be centrally acting muscle relaxants that are used to decrease the amount of force that the muscles are using, the hyperactive forces on those muscles. You can kind of see highlighted: temporalis, pterygoids, the masseter. If you go back to that very first slide where we have the anatomy of the patient, it's important to understand where these medications are kind of working, right? And like we talked about, physical therapy. These are things that you can kind of do at home. This is called the Therabite appliance. You can have the patients open it to a certain amount, and then they can click on something that slowly opens their jaw, so it can help them increase their active range of motion. So this is one of the conservative modalities that you want to make sure you're discussing with your patients, because it's important to understand all the aspects that you could do for patient care in regards to conservative therapy. Like we talked about earlier, there's also occlusal appliances that can be used. They can see the general dentist to have these things fabricated in the office, and that kind of helps prevent bruxism and clenching, and it helps reduce hyperactive muscles that can cause more TMJ disorders. So this is an anterior repositioning splint. Why is that important? Because of this part right here. So if you go back to that slide with the anatomy of the condyle and the disc, this helps position everything in kind of that normal anatomy. So it's important to understand that. And there's also behavioral therapy. Sometimes patients can have anxiety, so they're constantly biting their nails, or they could be depressed, so they're doing things like that. So you want to make sure you're screening for things like that, because maybe a referral is necessary, like some kind of psychiatric therapy where they can address that underlying cause. So if you remove whatever is making these patients very anxious or very depressed, then that can kind of decrease their behavioral habits, which can lead to alleviation of their symptoms. So it's important to get a general understanding so you know when to refer to the psychiatric care or not. So I want you guys to understand, there's some surgical management of the TMJ. Like we said, throughout the slide, it depends on what you figure out from your X-rays and from the clinical exam. The most important is whether it's limiting their function, their day-to-day activities. If they're having pain, then that's when you'll do a trial of that conservative therapy. And if that doesn't work, then you want to look into surgical management for that TMJ. And it's important, like you guys know, I'm sure, anytime you have an X-ray, you can't just base your treatment off of that X-ray. You have to have your clinical signs and symptoms and put those two together, and then that kind of tailors your form of treatment. So remember, radiographs, it's a supportive role. It's not, you can't base your treatment just off of that. You have to combine the two together. So this is an important slide here. I want you guys to understand, the indications for TMJ. Some can be absolute, some can be relative. Let's say the patient has a certain tumor, they have a growth anomaly that, it can't be changed with conservative therapy. Or if there's ankylosis of that joint where, it's fused and, you can't open it at all. Those are some absolute indications. What are some relative one? Internal derangements, like we talked about, disc position, could be with or without reduction. Integrity of the TMJ components. Are there a lot of adhesions in the TMJ? Is there a lot of inflammatory disorders going on? Or if they have just generic osteoarthrosis of that joint. This here is just kind of a classification that we use anytime we have a patient that comes in with TMJ. You have your clinical findings, your radiographic findings, and your surgical findings. So they have different stages here. I'm not expecting you guys to kind of memorize this, but I want you to be familiar with it because it's terminology that's commonly used when describing patients with TMJ. So you can see you have your patients in the early stage. These are some things you might notice clinically. They'll have painless clicking and no no restricted motion. If you look at the imaging, you'll see normal osseous contours. There could be some disc, reduction of that disc. And then surgically, there's a normal disc form. There's could be slight anterior displacement, things of that nature. Then if you look at the late stage, it kind of tells you how different it is. So there could be pain, crepitus, pain with function. So just kind of familiarize yourself with that. I'm not expecting you guys to memorize that, but just have an understanding, because oftentimes when you have a TMJ patient, this is what we use to kind of categorize them, okay? So this is another, I know we talked about this earlier, but that's another, I want you guys to be very comfortable when you're looking at, certain anatomy and just understanding the basics. Like that, I can't emphasize that enough. If there's one thing I want you guys to get out of it, is just understanding basic anatomy and, what problems that can lead to, okay? Let's see here. So here we have some surgical options. We talked about arthrocentesis a little bit. I want to go into detail about a couple of these here. We have arthroscopy, condylotomies, and then open joint surgeries. So these are kind of things that we'll look at a little bit here. Can anybody tell me what they think arthrocentesis is? Have you guys seen a video of arthrocentesis? Yeah. So it's kind of like an oil change, but for your joint, right? So you're just kind of rinsing everything out a little bit. So huh? No, it doesn't have to be swollen.
So they're using a needle to empty out the.
Yeah, so I'll talk about that here in a second. So oftentimes you're aspirating that fluid cavity and then you're injecting it with another substance to kind of rinse that area out. So it can be either diagnostic, because when you're aspirating whatever is there, you can see what's going on, or it can be therapeutic, because when you're rinsing it out, what we call lavage and lysis allows for removal of whatever those inflammatory products are. So like we said earlier, joints have synovial fluid, right? So if that fluid is very inflamed, this is a procedure that can help with that.
We don't replace it fluid?
Say it again?
We don't replace it fluid?
You do, yeah. You're injecting a different fluid in there. And I'm going to go into detail about that here in a second. So, some indications for this are arthritic conditions. If there's a lot of, arthritis in that joint, they're having internal derangement, which is kind of the same thing. Or, a post-surgical procedure. If they've had a surgery before and there's still, very limited opening, then sometimes, doing a lysis and lavage and cleaning that area out can allow for increased mobility of that joint. So kind of like what Julian was saying here, you have your first needle here in this area, kind of washing up the joint, and the second needle is attached, and that removes excessive fluids. So I'm gonna see if I can play a video for you guys in a little bit here that'll help you kind of understand that. But these pictures kind of show what's going on. So you're introducing fluid right here, as you can see on the A right here, into the superior joint space. And then when that's successful, you can remove any adhesions or fibrillations that can allow for better translation of that compound. So when we say you're introducing the fluid into that joint, what are some things that we're giving? Well, here you have it. You can introduce steroids into that area, okay? I'm not expecting you guys to know the exact dose here, but I just want you guys to know what you can inject in that joint to kind of help alleviate the pain in that area. You can do hyaluronic acid, and it tells you kind of how it works there, or you can do botulinum A, kind of like Botox in that area there. So you can use an appliance post-operatively to reduce the pressures on that area, and it can preserve the effects of arthrocentesis.
Is that like a mouth?
What'd you say?
Like a mouth?
Yeah, like an occlusal appliance.
Okay.
Yeah. So what are some of the advantages? It's not an extremely invasive procedure. It's pretty low risk, and it's relatively straightforward to accomplish. Why is that? Because if you're familiar with the anatomy, like I had in the pictures that you guys were seeing on the previous slides, then it'll kind of help you understand that. So let me see if I can play something here. guys see the thing? That's kind of what it looks like. So let's talk about arthroscopy. Let me go over this side first. So this is kind of what you're looking at. I don't know if you guys have seen a knee replacement or something like that before, but it's kind of the same thing. It's basically a procedure that's very good with diagnosing and treating like problems that you have in the joint. So basically the way it works is, a surgeon will insert kind of a very narrow fiber optic tube, and that is just like a very magnified video, and there's like a big screen so you can see that joint magnified onto a screen that's about this size here. Allows you to see what's going on inside the joint, allows you to see attachments, things like that. See, visualizing with your own eyes what's exactly going on. Yeah.
So I know that there are some dentists who choose to specialize
And like TMJ stuff.
Yeah, so are they doing this surgery or like
I would
oral
assume so. I
surgery?
didn't know that there is that, but I'm assuming, yeah, if they're specializing in stuff like that, then for sure they'd be doing, procedures for TMJ. Yeah. So, these can be diagnostic or operative, as you guys can see here on the slides. Some patients can come in with unexplained pain that's just nonstop. Medical forms of therapy, you should be considered prior, like we said before. If that doesn't work, then you can kind of go into surgical procedures for that. What's the use here? It's used to wash out and remove inflammatory substrates or mechanical barriers. So that's why you want to visualize what's going on. And then once you visualize that area, then you can do, arthrocentesis, a washout, or you can, do other surgical procedures once you're able to see what exactly is wrong with that patient. And then there's a condylotomy. So condylotomies are kind of like, you have limited joint space, so sometimes you can do a surgical, osteotomy in that area to free up that bone and increase that joint space a little bit. So that's kind of, the purpose of condylotomy. So there's anterior medial displacement of the condyle, as you guys can see here in this image, and you're increasing the joint space. So instead of it being right up here like this, you're making an incision in that area. So now instead of it right on that fossa, grinding right on that fossa, now you have a little bit of space. Because of this incision, you have a little bit of space right here between the head of that condyle and that area there. Whereas here, if it's constantly grinding on that area, then patients come in with pain for that, right? This is kind of a procedure that you can do.
So it's incision right?
Yeah, yep. So you can do it. You can do it intraoral, extraoral approach. You guys don't have to worry about that. But yeah, you're making osteotomy kind of in that area there, and that's increasing the joint space. So you're starting off like this here, and you're ending with a little bit of space in that area. Okay?
I'm assuming you put plate in.
No, actually, you don't have to plate it. So I've done one with Dr. Danielle where we didn't plate it. We did leave it like that. So.
What have you mobility?
No, there's no ability. Yeah. So, and then there's total joint replacements. So, these are some of the indications, as you guys can see here on the slide. You guys can see that for yourselves there. These are indications for a total joint replacement. And then there are some certain limitations and contraindications. You want to assess the age of a patient, see if they're still growing. If they're still growing, then that might affect the anatomy of that joint. Are they psychologically stable to have a procedure like that? Will they need another surgery afterwards? Do they have unrealistic expectations? Like we said, we're alleviating pain in these patients. So those are kind of things you want to assess before you go into a major surgery like that. So they have to be, kind of prepared to cope with, permanent loss of that body part. I know it's something we might not always think about, but some patients, you never really know what they're actually going through. So they have to understand that a revision surgery, meaning a second surgery, may be required in the future. Is that something they're willing to accept or not? Like we said earlier, do they have, you know, unrealistic expectations of complete relief of their pain, or are they expecting it to be alleviated by whatever surgery you're doing for them? You know, so what are the things you want to address, you know, prior to, you know, opening somebody's joint and replacing it completely, right? So this is kind of an image here of, you know, what a total joint replacement kind of entails there. And that's it. Appreciate you guys. Thanks for having me. Really appreciate it.